Murray PHN acknowledges its catchment crosses over many unceded First Nations countries following the Dalconyoga Look. We pay our respects and give thanks to the ancestors, elders and young people for their nurturing, protection and caregiving of these sacred lands and waterways, acknowledging their continuing cultural, spiritual and educational practices. We are grateful for the sharing of country and the renewal that country gives us. We acknowledge and express our sorrow that this sharing has come at a personal, spiritual and cultural cost to the well-being of First Nations peoples. We commit to addressing the injustice of colonisation across our catchment and to listening to the wisdom of First Nations communities who hold the knowledge to enable healing, and we extend that respect to all Aboriginal and Torres Strait Islander peoples. So thank you very much for coming tonight. So I'm Janice Radrekusa, the Director of Operations for Murray Primary Health Network. And I have a great team with me, and I can see Emma Harradine there, and I think Sue Keane as well, who work closely in the team and has been part of the development. So tonight we're just going to give you just an overview of the PPCCs, what we went out to market and the commissioning results that we have so far for Murray PHN, purpose of a PPCC, key features and elements. We will just give you a little bit of information around the Commonwealth Medicare Urgent Care Centre, the PPCC governance framework, statewide clinical reference group, the local working group members, the inclusion and exclusion criteria, and all about the Wodonga PPCC site. So we'll just start quickly because it gives you an opportunity to ask any questions that you might have. So just to give people an overview, the Victorian Government is working with primary health networks to establish 25 new GP-led priority primary care centres to give Victorians the care they need while easing pressure on the emergency department. So these were established and are being established across the Victoria in the first instance. So basically the state government is funding PHNs to commission general practice clinics to develop these service models and to work closely with a defined health service. And tonight, obviously, this one is to work closely with Albury Wodonga Health. So when they first started, the department first funded 5 proof of concept sites, and they were funded for 15 months of operation, and they commenced opening from September to December, and I think we've got about maybe 7 of those open now. The first 5 were then extended to another 20, and the other 20 are open for like a 12-month period until the evidence indicates that they're a great service. Murray PHN received notification of funding for the 4 Bendigo, Mildura, Shepparton and Wodonga sites, and we've since rolled out an EOI and working with those that are successful. So the 2 that we can tell you about at the moment is Shepparton Medical Centre is been awarded in the Shepparton area, and Sarcon Medical Centre in Wodonga. So that's what we're here to talk about tonight. So we're very excited to let you know about the progress we've made. So the purpose of the PPCCs, they're GP-led services that provide urgent care for low acuity presentations, your typical Cat 4 and Cat 5 presentations. They're to provide an alternative care pathway for people requiring urgent but not emergency treatment. They reduce demand on the hospital emergency departments, and they support people to access urgent care that's closer to home. They were partnered with an emergency department and a health service, and that's Albury Wodonga Health. They will see minor presentations, and there will be clear referral pathways, which we've been developing, and discharge protocols with health services, Ambulance Victoria and GPs as well. And core staff includes GP, nurse and admin staff. Services are free for patients with or without a Medicare card. And Niranjan will talk more about what they've got set up there and what it's going to be looking like. So the department's funded the setup and establishment of the clinics. and will also continue to work with us on block funding as well. They are block funded as well as MBS. So MBS revenue can be claimed. So really the key features of, and this is a standard item list here, is that it's supposed to support private treatment rooms, waiting areas, and suitable ambulance access, etc. Telehealth appointments can be made, but the preference from the department is that they're after the first one and can be like a follow-up appointment, or in some instances, if there's concern around particular issues, then it can be a telehealth appointment. Accessibility, so they can be open up to 16 hours a day, 7 days a week. And pre-booked appointments can be made, but that will let Neera and Jan talk about those. And referrals can occur from Ambulance Victoria, the VVED program, the emergency departments. Walk-ins are also accepted, of course. As I said before, the staffing and workforce that we've been Neera and Jan's been recruiting to, the patient cohort, as we also said before, and no cost, and it's really important that the staff are able to service and look after people with diverse backgrounds and be culturally appropriate in that space. Also spoken to about referral pathways and other ancillary services or access to those, imaging, pathology, pharmacy, etc. So just to give a little bit of an update, a lot of the general practices you might have heard around the planned Commonwealth Medicare urgent care care clinics, they're calling them. So there is, they have the Australian government, which I think prior to the election was announced as a promise, which they are still going to do, to fund 50 urgent care centres across the whole of Australia. And they'll be working with PHNs and the states in that space. Key features of the proposed Commonwealth model vary pretty much the same. The model is the same. They've got a operational guideline that's very similar to what we're doing. The Victorian government, they've engaged quite early with the Commonwealth so that we're aligning the work and the models of care. And there's no break-in service models if any of them transfer across to Commonwealth versus state or both. Locations are still being confirmed for the Medicare urgent care clinic, so we don't know. They're hoping to be operational from the early financial year 2023-24. That might be a bit longer than anticipated. Just so that everyone is aware of, there is a statewide clinical reference group and a project reference group as well. The statewide clinical reference group for the PPCCs, they have representatives from all peak bodies, including the RACGP, the AMA, AV, Health Services, and it's chaired by Safer Care Victoria. So they've made recommendations around the inclusion and exclusion criteria. They say it's not an exhaustive list, and it's obviously clinical assessment will often determine whether they should be there or can be there. So that's a really good. And from that, North West Melbourne PHN coordinate a community of practice across the state. But every PPCC locally, we have a local working group. So we have established nearly 4 local working groups, and we have one established for this site as well. Because we're really reliant on our key partners working with us to make this happen. So just a little bit more overview. The statewide clinical reference group have developed the inclusion and exclusion criteria. They're in the process of still developing the referral protocols and pathways, but we've developed our own locally. And they've also developing a scope of practice and training and development, and that is still in development as we speak. So just so that I'm not sure whether you can see this really well, but that's the list of our local working groups who's been involved in the development of our local protocols, and just the SMEs that have helped us and informed us of where to go next. Jo Brooks, who's been a very great supporter, and she wasn't able to attend tonight, but she's available if you've got further questions. So just the inclusion and exclusion criteria, so that everyone is aware, we will be sending out this PowerPoint presentation, so you'll have access to it, and the recording as well. So if there's any questions asked, you can hear the responses to those questions. So the inclusion and exclusion criteria is listed there, so I won't go through it so you can see it, but it's really any injury or illness that is suitable for management in a primary care setting, requires a same-day review, unable to access their usual GP, and the only other option would be to go to ED. So that's where it's nearly, it's really a valuable service. Nearly up to. So this is really, I'm going to hand this over to you and Jan. Just let me know when you want me to move to the next thing, but did you want me to open up to questions first before you go? Has anyone got any questions they want to ask at the moment before we get Nir and Jan to talk through components? Can't see any hands up, so go forth, Nir and Jan, if you want to start with this slide.
Thanks, Janice. Thanks, everyone. So just to give an overview of all the setup before we go into the slides. So this is a exclusive facility that we have developed for this project, priority primary care center. This is the only clinic which I know of in Victoria that we have done as an exclusive clinic compared to the other ones. They're part of the GP practices. We have around 4 consulting rooms, then one treatment room where you can, we are going to put 2 beds there for treating, acute care. And we'll have ample seating capacity inside, and we'll have sufficient medical and supportive staff to cover our workload. So we have an isolation room. If we in our screening process that we identify that someone with a respiratory illness, they will be taken directly into the isolation room for the assessment purpose. So in terms of operation, Janice, could you please go back one slide backwards, please? So we open 9 to 6 to start off with from this week, which is on Friday. We were hoping to do it much before Friday, but due to the supply chain issues, and we have now finally scheduled for the 3rd of February to start. We'll start with 9 to 6 to start with first 4 weeks, then we'll just increase those hours. Saturdays, again, will start after 4 weeks, not in the first 4 weeks. Then we are hoping to open between 8 to 8, and we are waiting for some data from the emergency department to see the trend and how people, what time is a peak time that they're presenting to ED, and also Cat 4, Cat 5 presentation trends. We're just having a look. Initially, we go for soft launch, in terms of the communication, social media, marketing. Then we are going to go on an aggressive patient community, information. Next slide, Janice. So Capabilities and capacity of our center. So we'll be equipped with all standard 5 RACGP. In addition to that, we'll have emergency equipment and trolley, which can basically treat whatever the emergencies that we could manage. We'll have a AED and ECG and LMS. There'll be a X-ray available for our patients with a, for example, if someone comes with a ankle injury or any limb injuries, we could get a X-ray and manage accordingly instead of sending the patient to either to the local radiology provider or to the hospital. That will be little bit inconvenience for the patient. For the patient convenience and good operational and effective way, we felt X-ray, bringing the X-ray on site will be much needed. All our treatment room beds will be radiolucent bed, so that way you can take X-ray. We don't need to move the patient between the examination bed to the X-ray bed. We'll have spirometry, and we are looking to get a microscopic assisted ear irrigation, and also can be used for the foreign body removal. Urinary catheterization we can do, vascular Doppler ultrasound, and we do going to stock some SAID medications, but it's only used for only the patient who comes with acute injury, not for the ongoing pain management or script. So we are going to have complete fracture management and treatment set up in the center. Either it could be cast, it could be back slabs, moon boot, crutches, whatever is necessary for Cat 4, Cat 5 fracture management. We take only the closed fractures. If it is an open fracture or complex, obvious deformed fractures, they will go, if they're coming through an ED, they will go, if they come through the ambulance, they will go straight into the ED rather than coming here. So we do treat minor burns, wounds, either it could be wound suturing or gluing, manage minor lacerations and respiratory illnesses. But COVID patients management, something that we got some protocols, will follow those protocols. So this is essentially basically, Cat 4, Cat 5 presentations, which can be offloaded, the workload on the ED department. Next one, Janice. So referral pathways, we do get from multiple, you can see the list on my left-hand side. Either it could be from the emergency department, or it could be from virtual ED, walk-in patients who can come in. So pre-booked appointments, we don't open, they can't pre-book the day before. They can book only within 2 hours. We might get a patient from the nurse on call, ambulance Victoria, and also the local general practitioners, or we can get from allied health referrals too. So our responsibility is we do the triaging of the patient. We got a dedicated nurse who looks after that part. Then we'll do the assessment and we manage accordingly whatever the investigation that needed for that patient. So once we manage and give appropriate advice, either referral or discharge. So the discharge summary will be sent back to a copy, sent back to the regular GP with the copy of patient discharge summary will be given to the patient if they don't have a regular GP, but will definitely give a list of GPs locally and they can choose. We don't follow up. We'll encourage them to go and see the GPs in a depending upon the condition. So all the discharge summary will be faxed to the regular GP within 24 hours. Next slide.
Just Niranjan, you have a question in the chat. If you'd like to, I'll just ask you if that's okay. Will there be a point of care pathology?
So yeah, so we'll have we'll take the blood samples here initially, then we'll have a collection center during our operational hours.
Yeah, thank you. There's another question which we know the answer, but we'll give you that. Will there be prophylactic vaccination access, for example, treatment of minor lacs and burns, such as ADT? Yeah,
we will have ADT and also IV antibiotics, not usual antibiotics in our fridge because the pharmacist will close here by 5:36, so patients can access. And we'll also have infusion pumps and syringe pumps for those purposes.
Good. Another question is, will there be a radiography on site, or will clinical staff need training to do simple X-ray vascular ultrasound?
So initially, we'll be using the third-party imaging services locally here, and we are in the process of getting the licensing, then the training. That is like a few weeks away. It's not going to happen within the next 6 weeks.
Fantastic. So the last question we have in the chat, before I go to your next slide, can you give patients a copy of discharge summaries, as there are often delays in us receiving letters from hospitals and other clinics? My clinics issue usually, in brackets.
So as I said, if the patient is going to see their regular GP within 24 hours, we'll give a copy of the discharge summary to the patient for them to take it. Plus, we are going to fax the discharge summary within 24 hours. And we are looking at some other secured, communication system because not every GP or GP practices are in that secured communication system. So if there is some, then we can upload there. Then also we might upload onto the My Health Records.
Yeah. If I could just add to that, Niranjan. So I guess it depends on the clinical situation. If we have a patient that we feel needs a follow-up, say within 48 hours, we may give a copy of the discharge summary to the patient. So in case the discharge summary is missed by fax reaching their GP, the patient also has a copy. So the GP will have an opportunity to understand how the patient was managed at our center. But the protocol that we have in place is that every patient who is seen will have a discharge summary that is sent to their nominated general practitioner. If it is a more urgent situation, we will give a copy of that to the patient, so the patient has it on hand to present to their doctor.
Fantastic was the comment in the chat. So that's good. Yeah. And just so that our local working group will be reviewing we're discussing any risk or things that might have come back and fed back, and figure out how we can work together to improve the flow as well. So I can't see any hands up, so I will go to your next slide, Niranjan. Yep. Which is a good one.
So this is our key contact numbers for everyone. So there's a dedicated phone lines and the fax number, and we are going to distribute to all the practices and the general practitioners for the records. So these are some of the emails that you can, if you have any questions, that you can directly address to these emails, and it will be especially the second and third email will be on live, so they can be picked up very soon if you are sending a referral. Next slide, Janice. So this is something I just thought of putting here. So we do need support and the help from the local general practitioners. This is something that they can also have a hands-on in this facility. Just to request to anyone who's interested to be part of this service, please do not hesitate to reach out to me. My number is there, or you can reach out on my email address.
And also to add to that, we would like to warmly welcome all the local GPs. Please, if you have 10 minutes to spare, please come and see the facility. We have worked hard to set it up, and any input you give us, it would be valuable. And we really look forward to welcoming any GP who wants to have a look and give us suggestions. Thank you.
That's fantastic. Yeah, so I'll just go to the next one. What is that? Oh, that's ours, ability to be an anti-racist company. So I'll just go back there. So is there any last questions that anybody has, or any comments from anyone around the team that's been on the local working group? No? Okay. I can't see anyone else with any questions, but you can use this chat as well that we've been chatting in tonight if you do have other questions, or you can email Niranjan as well. So it's just to give you some information, when the first 5 started in Metro, 4 in Metro and 1 in Western Vic area, such as Ballarat, in the first couple of weeks, the referrals, 50% of the referrals were from ED. The other 50 were from the virtual ED program. So now they're getting a mixture, certainly from the VED, AV, the EDs, but they're getting walk-ins and booked appointments as well, nurse on call, health direct, etc. So I think it's promising. As the manager of the VVED program, they would be, they're very keen on developing, working in collaboration with the Commonwealth and as well to sort of provide a wraparound service for people. So I've got one question. I'll go to you, Megan. But funding, did I hear correctly? It will be state funded, but also with Medicare billing. That is correct. Yeah. Knowing that you need a certain amount of throughput to get MBS revenue, so that it's going to be attractive enough to maintain operations. So that's how that will work. So Megan, I'll go to you first before I go to the next question, if that's okay.
Yeah, no worries. I just wanted to briefly say, having sort of been part of a community where we had immense pressure. I was both a GP and working in the emergency department where we set one up in New Zealand. It was brilliant. In our town, we had overworked GPs and our emergency departments with huge wait times, and having that sort of middle section of having an urgent care to take a bit of the pressure and those appropriate patients off both of those services worked really well. And just to emphasise in terms of the general practitioner and the continuity of care, an urgent care centre is in no way trying to take away from any of that work. And it's about acute episodic care of patients. Essentially, when they need a doctor, like it said in one of those early slides, on the day, they're not able to get into their GP, or their GP can't provide that care, like for a minor broken wrist or something. It really does help with the care of all our patients out there in Albury, Wodonga and the surrounding areas.
Fantastic. So if anyone's got any questions, just pop them in the chat for Melanie, and then we can take it from there. Sorry, Megan. Well, and so the other question is that from Angela Stratton, and it says, will they do procedural sedation and regional blocks for closed fractures? That's a
yeah. See, we will have nitrous oxide on site. Then we'll have morphine. The issue here, we need to be careful what is safe to do it, if in case if we get into trouble. So initially I would say no. So we just use those two pain management to we don't do the close reduction to in this center. So we'll just stabilize the fracture, make the patient comfortable, get the proper diagnosis, and get the proper referral and the follow-up.
okay. Thank you. Okay. So I can't see any other questions come up. And thank you everyone for your input. We will send this presentation through. Angela says thank you for that. But any developments, any increase or decrease or in capability of the clinic, we'll let you know what's going on. If there's anything that comes up, if for instance, if the centre gets presentations of a particular one that might not necessarily we have the capability and it's not on the list, we'll take it to the clinical reference group, the statewide clinical reference group. Prior to that, we'll take it to our local reference group and then to the clinical if we think it needs to go further, so they understand what we're asking and they can endorse it or not. Yeah. So I think that's it. Yeah. No further questions.
I would once again, ask all the general practitioners to come and visit the center and to give the feedback so that we can improve on the service.
Yeah, and we want to work together as a team with all of you.
Yeah, and definitely we should, if they want to have the hands-on, I would say they can come and work and get that hands-on. It's a little bit different from the general practice work.
Yeah.
So we can have, if we get more GPs, then we can have some rostering system in place for everyone to accommodate.
If we have enough interests.
Yeah.
Okay, I think that's it then. We'll circulate all of this information through. So at this stage, the clinic will be open on Friday at 9 o'clock. Is that correct?
Correct, Janice?
Yes, and the trucks have sometimes gone missing in action, but they're all on their way for delivery. So that will be fantastic. And I have to commend everyone in our working group. They've done an enormous work, and I know people have worked after hours, in hours, over weekends, and everyone around the table has. On holidays, people have advised and sent back information to make this work. So it's been fantastic. So please let us know if you've got any concerns or other questions, and we're very happy to take questions. Thank you, everybody. You have a great night.